Well, welcome everybody to this wonderful and exciting webinar we have planned for you this afternoon on the 5th day of March 2024. Our title is Modern Management of Breast Cancer During Pregnancy, a case-based conference. So this is an NAPBC webinar today, and we have a lot of great speakers who specialize in caring for patients with breast cancer. I'm Asa Carter. I'm the Senior Manager for Education and Training in ACS Cancer Programs, and I'm thrilled to be able to introduce this webinar today. Just a couple of housekeeping items before I turn this over to our moderator. Remember, as you heard from the announcement, everybody is muted during the webinar. If you have questions, including any technical issues like you can't hear or you can't see or something like that, make sure that you submit those to the question pane that you find on the right-hand side, or at least on your menu. It should be on the right-hand side, usually on your screen. We will be recording the call today, and the recorded content will be posted to our NAPBC website later today, so you'll be able to listen to the recording then. We are not offering any credits for this webinar this afternoon, so there won't be any credits to claim. You will, however, receive afterwards an evaluation of the webinar. We ask you to fill that out so that we can know what kind of topics you're interested in, and we can also make sure that we improve our future webinars. So with that, I am excited to be able to turn this over to our moderator for today, and that would be Dr. Jane Mizell. Dr. Mizell, I'm going to go ahead and mute myself, and the webinar is all yours.
All right, thank you so much for the fabulous introduction. We're really looking forward to tonight, and this is going to be just really a case-based dive into some of the key issues that we uncover when we treat patients who are diagnosed with breast cancer during pregnancy. Such a challenging situation, and one that really requires multidisciplinary management and a very sensitive approach to our patients. So we've got an all-star panel tonight, and I'll just briefly introduce myself and then let my colleagues introduce themselves. And after that, we'll dive right in. So I'm Dr. Jane Mizell. I'm at the Winship Cancer Institute at Emory University. I've been here for about 10 years. I'm a breast medical oncologist here at Emory. Erica Mayer, you want to take it over after that?
Yeah, thank you so much. And hi, everybody. Thanks so much for joining our event tonight. I'm Erica Mayer. I'm a breast cancer medical oncologist at Dana-Farber Cancer Institute in Boston, and I'm really delighted to be here with my colleagues. So I'm going to now pass it over to our lovely surgeons, Dr. Cavillo.
Hi, everyone. Again, thank you for the invitation, and I'm really happy to be here. My name is Kathy Calvillo, and I am a breast surgical oncologist, and I had the pleasure of working with all of my colleagues while I was at Dana-Farber for nearly 20 years. And then a little over a year ago, I opened up a private practice here, and I continue to do breast surgical oncology here in Boston. Olga, on to you.
Great, thank you for having us all today. I'm Olga Cantor. I'm a breast surgical oncologist at Brigham and Women's Hospital and Dana-Farber Cancer Center. Dr. Economy.
Hi, I'm Kathy Economy. The important thing to know about me is that I am not an oncologist, a breast oncologist or a surgeon. I'm a maternal fetal medicine specialist. I have been practicing at the Brigham and Women's Hospital. I arrived in 1996, and I have had the very great honor of also being colleagues with the other people on the panel, and I am delighted to be here today.
Perfect. Thank you so much, everyone. And Asa, you can go ahead and advance the slide, and we'll dive right into our first case. So we really designed these cases after things we see in our clinics, thinking that would be probably the best way to generate discussion and to really help you all who are attending to understand how best to manage these patients. So our first case here is a 41-year-old G1P0. She's 28 weeks pregnant, and she presents after her OBGYN palpated a mass on a routine physical exam. She has a breast ultrasound done that identifies a 1.8 centimeter mass that's then biopsied and is found to be an ER positive at 94%, PR positive 92%, HER2 2+, FISH positive breast cancer, so triple positive as we would say. And her axillary nodes appear normal. So there are a number of questions to consider. And Asa, I'll have you advance the slide just so we can kind of take a look at some of those questions together. And I'll start maybe by asking Olga, can you talk to us a little bit about breast imaging during pregnancy? So this patient pops up in your clinic, 28 weeks pregnant, with a new mass that's been identified to be a cancer. How do you then go about imaging in terms of what you would do for this patient, and how would you approach this going forward?
Great. So really common situation to have someone present in pregnancy with only an ultrasound and a biopsy. Most imaging centers will not do mammograms routinely in pregnancy for the obvious reasons, but once we have a cancer diagnosis, it is really important to complete the breast imaging. And so most centers, as long as the providers ask for it, will do mammograms with double shielding of the abdomen, to try to minimize exposure to the fetus. And I think that mammograms are important, and we want to make sure at this point, once we have a cancer diagnosis, that we're getting a bilateral mammogram as well, not just addressing the cancer side. Most of these women have never had breast imaging before, as they're quite young. So definitely ultrasound. Any other palpable findings should also be evaluated on ultrasound, of course. And then, breast MRI, gadolinium is contraindicated during pregnancy. And so breast MRI without contrast is not particularly helpful. So usually do not use this during pregnancy. So really just mammogram and ultrasound and clinical judgment.
Okay, perfect. I think that's really helpful, because I think there is a lot of sort of common sense out there. Some people really they do shy away from mammograms. And I think knowing that with shielding it's appropriate to do, especially for a patient with a breast cancer diagnosis, is very, very helpful. So that's great. And then what about surgery? This is obviously a big topic, but Dr. Calvillo, I'll maybe ask you to comment a little bit on how you might approach this patient, on the timing of surgery, and then like what type of surgery you would potentially consider for her. How would you take it from here if you were seeing this patient in your surgical clinic post-diagnosis?
So great questions. And when we talk about surgery, especially in a patient diagnosed with breast cancer during pregnancy, what's really important is obviously what trimester that they are in, because that really impacts what our surgical conversation is going to be. So typically, if we just think about it in trimesters, typically in the first trimester, it's really reserved for mastectomy. But as we get further along in the pregnancy, in second trimester, third trimester, obviously mastectomy is potentially always an option for patients. But then the conversation about breast conservation can come into play. The really important thing to consider when we talk to patients and when we're considering different surgeries is, if we were to be able to, based on timing, the type of cancer that it is, perform, for example, breast conservation in a lumpectomy. What's really important is obviously talking with our medical colleagues what the medical treatment's going to be, but not to delay the radiation therapy. So really thinking about where a patient is in their trimester and not to delay that radiation therapy.
Got it. So for a patient like this who's presenting at 28 weeks and presumably with the negative lymph nodes and a small-ish tumor, clinically stage 1, surgery might be her first step in treating this cancer. You would be talking to her about either lumpectomy or mastectomy.
Absolutely. And again, depending too, talking, which is what we're highlighting today, is the importance of the multidisciplinary approach. What are the plans from a medical perspective? And, sometimes, that will impact our decision making as well. But as she's now in her third trimester, there's definitely the conversation about she's a breast conservation candidate. And again, without delaying that radiation therapy versus mastectomy. And obviously something, whether a patient is pregnant or not, it's the importance of obviously what's important to the patient and shared decision making and explaining the differences with breast conservation, mastectomy, survival's the same. And so those types of things are also very important that patients understand too.
Yeah, no, absolutely. So I think there's that added fear that comes with getting a diagnosis like this while you're already pregnant, that can sometimes make it important to reiterate those things, even if you've said them once before. And then Dr. Cantor, can you comment a little bit on sentinel node biopsy during pregnancy and kind of how that works?
Yeah, so in a patient like this who's clinically node negative, certainly no reason to have to go straight to an axillary dissection. We do know that, the lymphatic dyes that we use for sentinel lymph node biopsy are safe during pregnancy. Technetium-99 is safe, and there's been lots of studies on that. Methylene blue, there's some mixed data out there, but I think, in general has been shown to be safe. I know at our institution, we kind of favor technetium. And if Dr. Economy has any thoughts or comments on, thinking about between options for sentinel lymph node mapping. I think we definitely have options.
Yeah, no, I think that's great. And Dr. Economy, I'd love to sort of bring you into the dialogue here. I think, one of the things we think about when we're thinking about surgery for, breast surgery during the second or third trimester is what about fetal monitoring? What do you do in a situation like this, and how might that change if it was first trimester versus third trimester? And how do you sort of think about a surgery in this case?
Sure. Maybe we could go back to the first slide, case one.
You can go back to the questions for slide 1 for case 1. Just go back one slide.
Sure. One more.
Go back as opposed to, yeah, go back. There you go. Perfect.
Right. So agree with everything that's been said. Just a word on mammography. ACOG actually recommends, screening every 1 to 2 years after 40. ACOG, which is the American College of Obstetrician Gynecologists, screening mammography. And for patients that are at high risk, they recommend that they continue screening during pregnancy. So for your high risk patients, for sure, we would recommend even screening mammography. And in a case like this, of course, where mammography may be helpful to the diagnosis, we wouldn't hesitate. The radiation is entirely directed at the breast, very little scatters through the spine to the fetus. And the amount of radiation is actually quite small. So in terms of timing of surgery, I think that it's as others have mentioned, sort of a complex interplay between what the patient needs with respect to surgery. Do they also need chemo? So I wait and I hear that from my oncology colleagues, and we try to plot things out so that the patient can receive treatment through pregnancy without any long gaps, get them safely to delivery. If they need surgery during pregnancy, we always start with what's the best medical recommendation, and then what are the patient preferences, and try to, I feel that my role is always to, the first thing that patients do when they get this diagnosis during pregnancy is they panic. And this case was discovered with an OBGYN doing a routine exam during pregnancy. And this is the time when young women are being seen by their doctors. Lots of young women aren't going to see their doctors regularly, and then they're pregnant and they show up and someone, gets this diagnosis. So we see this quite frequently as a new diagnosis. So I think when a patient needs surgery, if it's any time usually after 24 weeks, so the patient that we're talking about is 28 weeks gestation, we would recommend continuous intra-op monitoring, and typically will come and assist with placement of the patient. As long as it doesn't interfere with the surgical field, we like to have some type of uterine displacement, either a left lateral or a right lateral tilt, so that you don't get aortocaval compression and supine hypotension during surgery. We'll monitor the patient with external fetal monitorings, and we can also use the fetus a little bit as a vital sign. So if we see changes in fetal monitoring, we might say we can improve mom's blood pressure a little bit. So I think there's lots of opportunities for us to be helpful in these cases.
Awesome. No, I think it really highlights how important it is to all work together, and really once this kind of diagnosis is made, to get maternal fetal medicine involved along with surgery and medical oncology right away. And then what about timing of delivery? Do you think about that at all at this stage, or talk to your patients about that at this stage?
Absolutely. So we know that the baby, that term is 37 weeks gestation, which is 3 weeks. 40 weeks is the due date, and 37 weeks is 3 weeks before the due date, but we consider that term. So our goal is to try to get patients to term, but we know from large studies that the babies continue to develop and grow from 37 to 38 to 39 weeks, and 39 weeks is really the sweet spot for a baby that will have no expected complications of prematurity, is very likely to go home with their parents, not need time in the NICU. And sometimes when we think about the trade-off between wanting to deliver a fetus preterm so that we can start the mother on the next step, we forget that, well, then the baby's going to be in the NICU, and the mom's not going to want to start her chemo right away and be taking care of her baby in the NICU. And so all of these things that, we can really move the needle a lot when we work together with patients as the surgical team, oncology team, and MFM team to sort of put patient preference front and center. And again, just help them understand that despite having this diagnosis, they can still have a normal pregnancy, and they can still have the pregnancy that they were hoping for in many ways.
Yeah, no, I hear you. Okay. That's great. And then speaking of, thinking about the whole picture and then the oncology piece, Dr. Mayer, I'd love to hear your thoughts. I mean, it sounds like this is probably a patient, we all would agree, who's going to have her surgery, deliver, and then likely start her systemic therapy. I think one of the challenging things that we encounter with HER2 positive breast cancer during pregnancy specifically is that our HER2 directed agents really can't be given during pregnancy. So how would you approach systemic therapy in this patient, and what would you be thinking about in terms of timing and drug delivery and all those kinds of things?
Yeah, thank you. Great. And, these have been great points from the panelists. So, just to take a step back, when we approach a patient diagnosed with breast cancer in pregnancy, first of all, we have our two patients. We have the mother-to-be, our breast cancer patient, and we have the developing fetus. So we always have to be considering the effect of any treatment or exposure we're going to offer on both of those individuals. Additionally, we try so hard to get as close as we can to our standards of care that we would be offering the patient if she were not pregnant. And yet in every single situation of breast cancer and pregnancy, there's going to be an element of compromise. There's going to be some way in which the treatment slightly or majorly deviates from what we would normally be offering. And the challenge for all of us when we meet these patients is to figure out what is the compromise, how substantial is it, and is it something that we can overcome, or is it something that's actually a big challenge, and how does the patient feel about these compromises? In a situation of HER2 positive breast cancer, we want to think about, of our systemic therapies, which therapies can we safely offer in pregnancy and which ones can we not offer? We know classically that there are some of our very important and effective therapies that are not available in pregnancy. This includes endocrine therapies, this includes HER2-directed therapies, and as we'll touch on later, some of the newer immuno-oncology drugs or even antibody drug conjugates that are so important in our practice. And so we have to think about, what do we have available, when can we give it, and how can we give it? And in the setting of HER2 positive breast cancer, our most important treatment, our HER2-directed therapy, cannot be given in pregnancy. So we know that always has to be delayed, and there's a part of our compromise. Then the question is, well, how big of a compromise is that? How long will it take until the patient reaches the time when they can safely receive that therapy? This patient is actually pretty close to the end of her pregnancy, and by the time she has surgery and heals from surgery, and we'd be even thinking about initiation of chemotherapy, she's essentially going to be at term. And as Kathy said, how important it is to try to take these pregnancies to term. We are doing the infant, the fetus, a huge disservice if we try to take them out early, trying to sort of facilitate maternal cancer therapy, when actually we're going to probably expose them to much more risk by doing that than by leaving them in utero and continuing on with maternal cancer treatment. So in this situation, I think we could safely move forward with surgery, deliver a term healthy infant, and then launch into our HER2-directed therapy and likely chemotherapy as well. So it's fortunate that this was diagnosed towards the tail end of pregnancy.
Yeah, no, I was thinking the exact same thing. And I think at 28 weeks, as opposed to being diagnosed at 16 weeks, is really critical for this patient. And I think a lot of us are moving away from anthracycline use in HER2 positive breast cancers in general. But the other thing I was thinking about, and I wonder what your thoughts are, if she were diagnosed earlier, if this was a 16-week pregnancy instead, is this a patient where, assuming that the surgery revealed, 1.8 centimeter tumor and node negative, would you consider doing AC for 4 rounds and then Taxol and Herceptin after, or would you, still try to push to get her to delivery and then chemotherapy? Obviously, knowing there's not one right answer in this case.
Yeah, I mean, in a patient who is diagnosed with HER2 positive breast cancer earlier on in the pregnancy, the tools we have available include adriamycin, cyclophosphamide, and taxanes. And we know now from a broad literature that these agents can be given with apparent safety in the second and third trimesters. And so in patients with HER2 positive breast cancer presenting in the late first or early second trimester, we can give them AC ×4, we can give them weekly Taxol. We just have to delay the administration of a drug like Herceptin until the pregnancy is completed. This strategy tends to work reasonably well for stage 2 and 3 HER2 positive breast cancer. And we also know from the HERA trial, way back in the breast cancer literature, that giving Herceptin after chemotherapy, or in that trial was after completion of everything, provided similar benefits to giving it concurrent with chemotherapy. So we do know that it's okay to delay it. I think in this situation, if she truly had a stage 1 HER2 positive breast cancer and was diagnosed early on in pregnancy, then we're going to run into compromise, because we would have to end up giving her either more chemotherapy than we would otherwise, or we end up with a long delay. But thankfully, if someone has a stage 1 breast cancer of any subtype, that's a good prognosis cancer. And if they have a delay that's longer than we'd want otherwise, it's likely of limited clinical impact for that person.
Yeah, no, that's perfect. And that was so insightful. I think in the interest of time, we'll move on to case 2, but definitely all of us are happy to take questions at the end, and we'll try to purposely leave some time for that. So our second case is a 31-year-old, again, G1P0. This one is a 22-week gestation. She palpates an abnormal axillary lymph node. So a little bit different than the first case. She's palpating this abnormal node herself. She undergoes a mammogram and an ultrasound. As we've discussed, mammogram is appropriate in this setting. It identifies a 3.2 centimeter breast mass and at least 2 abnormal axillary nodes. The breast mass is biopsied and is consistent with invasive ductal carcinoma, this time ER 54%, PR 22%, HER2 negative, and KS67 33%. She has an axillary node biopsy as well, and that's positive for metastatic disease. So this is a tricky one. This is a patient who's got a more locally advanced breast cancer. She's ER positive, HER2 negative. She's presenting right at that midpoint, 22 weeks, a little bit earlier than our first patient. We can move on to the next slide that has some of the questions here. So we discussed some of this a little bit, but Erica, just back to you to discuss a little bit more about chemo administration during pregnancy and some of the timing. So if this person presents in your clinic, as you've mentioned, it is safe to give drugs like adriamycin, cyclophosphamide, and the taxanes during the 2nd and 3rd trimester. How would you be thinking about chemo for this patient, and how would you be talking to her about administering it? I think the framework you set out in the first case is so perfect of, sort of what would we do if this patient weren't pregnant? What are our options now that she is? And how do we sort of think about some of those compromises? What would your initial conversation be with this woman?
So in this situation, a young person with node positive breast cancer, high Ki67, kind of a luminal B picture with the low PR, it's looking like a situation where we'd want to be offering chemotherapy regardless. So, if she were not pregnant, we would likely be giving her something like dose-dense AC plus T. In this setting, we can actually do pretty much the same thing. We routinely give AC during pregnancy. This can be given either every 3 weeks or every 2 weeks. We can also give paclitaxel or even docetaxel in pregnancy. I want to stress that the current modern literature in breast cancer and pregnancy now contains a substantial amount of data supporting the safety of taxanes, including reports from our own work at Dana-Farber. And I routinely get questions from providers about the safety of taxanes. It is safe to give taxanes in pregnancy. My preferred way of giving it is to give weekly paclitaxel. Part of that is that often when we're giving taxane therapy, we are actually nearing the time of delivery. And particularly as we get closer to 36, 37 weeks, the baby might come, and we don't really want that happening when the patient is actively receiving chemotherapy. So we can do a lot better job of tailoring treatment as we get closer to the time when they appear to be getting ready to deliver. And this is when Dr. Economy and myself are perhaps seeing the patients together weekly. And if she says it's time to stop, then we know it's time to stop. Growth factor use can also be considered in pregnancy, and we've published on this as well. Typically, when I give growth factors, I like to give daily GCSF for days 3 through 10 of a 2-week cycle. So rather than giving Neulasta, although I think with a little bit more data, we might become more comfortable with use of depot GCSF as Neulasta. I would always be giving dose-dense for a triple negative or ER negative patient. For ER positive, I think one could go either way, and I sometimes will decide to give dose-dense versus not based on timing. So for example, if I'm trying to accelerate the process of getting the chemotherapy completed before the patient gets to be term, then that might be a rationale to give growth factor and get through it more quickly. Finally, I'll just say anecdotally, our pregnant patients receiving chemotherapy seem to tolerate it better than our non-pregnant patients. Why that is, I am not sure, because the body is so conditioned to tolerate carrying a pregnancy, that it also tolerates chemotherapy. But you know, I tend to, and I'm curious what others say about this, but I tend not to use some of our newer antiemetics like Aloxi and Emend. I just use traditional Zofran, dexamethasone, compazine, some of the older agents that we know are safe to administer in pregnancy. And I often find that patients need minimal antiemetics, even with a highly emetogenic chemotherapy regimen like AC. So patients actually seem to tolerate it. They do very well with treatment during pregnancy, and of course are very happy about the health of the baby.
Yeah, no, I think those are all excellent points. I really appreciate you taking the time to go through some of those nuances about the weekly Taxol, which I totally agree with. And I think that does make it so easy to be particular about when you stop at the end and allow that time for delivery. And I agree. I think my anecdotal experience too has been that patients who are pregnant do tend to tolerate chemo very well. I don't know if it's something about the hormones or about, you know, just their mindset at that time. Being grateful to be able to continue the pregnancy, as you said, and you know, kind of go through chemotherapy with that goal of delivery in mind. But it is, I've not found that I've had to steer away from the more traditional antiemetics into anything more more nuanced, which is a good thing. So I think we do have less data on some of the newer antiemetics in pregnancy, and it's better to not have to do that if you don't absolutely need it. So it sounds like this is a patient for whom you probably would be comfortable, and I would think doing AC and then a taxane weekly up until we get closer to delivery, and at that point really communicating very closely with MFM.
Yes, and starting in the second trimester too. Just a reminder, we don't give chemotherapy in the first trimester.
Right. No, and this patient was 22 weeks pregnant, so I think that would be fine. Where would you feel sort of less comfortable starting? I typically have not started before 16 weeks, just because I sometimes wonder about like the timing of when does the first trimester end, but I'd love to know what you do with that.
Like 13 or 14 weeks, usually, unless someone tells
me. Let's be honest, the first trimester, the baby is really quite well formed by 12 weeks. In fact, most of the organs, 8 to 10 weeks, you're going to be safe. The baby's not going to acquire a birth defect after 12 weeks. And so, and certainly that's when we think of, you know, transitioning into the second trimester. So yeah. I would confident, like Erica says, like certainly at 13 weeks for someone you really need to get started, you should feel very confident that that's not going to affect fetal embryo development.
Perfect. That's great. I think that's a very good pearl for our audience. That's fantastic. And then Kathy, bringing you kind of back into the conversation, if this is a patient who potentially could get the chemo and then you could time things so that she was doing her other interventions like surgery after delivery, what do you tell people about breastfeeding if this was someone who potentially wanted to breastfeed some before she got into the local treatment for her breast cancer?
Yes, and many patients do want to breastfeed. For a lot of patients, this is a really important part of sort of the delivery experience. I mean, and to be fair to pregnant people in today's environment, there is a lot of pressure to breastfeed. So if you walk into the hospital, there's pictures everywhere in birthing units of women with their babies and nursing. And, you know, it can be very, very difficult. I spend a lot of time talking with patients about this exactly because I think this is an emotionally tough thing for our pregnant patients with breast cancer. And if there's any way we can preserve a little bit of time to breastfeed, I always do it. I know we don't have any radiation oncologists on the panel, but those are the people that I get the most pushback from because they want to set their field and they feel that lactation changes the breast quite a bit. But ultimately, when we have done it, everyone has found it very rewarding. And I haven't received a lot of negative feedback from other members of the team. And it is an outsized sense of satisfaction for these patients who can breastfeed on the other side. In terms of the chemotherapy agents, each one has like a slightly different washout period. For most of them, we will have stopped them well before that time. But if it's somebody who's inadvertently or precipitously delivered perhaps between cycles, usually for Taxol, usually after 6 days, it's safe to breastfeed. I think the data for Taxol and Adriamycin are quite clear. Taxol about 6 days, Adriamycin about 13 days of sort of what we call a washout. For the cyclophosphamide, the literature is a little bit all over the place. You know, this is a drug that we give for other indications in pregnancy as well, lupus, for instance. And so it's interesting to me that we give it, and then women breastfeed for other conditions. But when it comes to the breast cancer literature, there's some more conservatism. You'll see anywhere from 3 days to 21 days to 6 weeks if you're looking at any amount of detection of cyclophosphamide in the breast milk. I usually use a period of about 14 days for these patients.
Got it. So it sounds like 2 weeks after chemo, you would feel pretty comfortable with them nursing.
Absolutely.
Okay.
Absolutely. And if it's just Taxol, 1 week.
Right. Perfect. Okay.
They can pump, so it's very important to initiate breastfeeding within the first, 48 to 72 hours. So we encourage them all to pump their breast milk.
Got it. That's so helpful. And then Dr. Calvillo and Dr. Cantor, what are your thoughts on surgery after breastfeeding? Do you like to have some sort of washout period from breastfeeding before you would embark upon surgery, or how do you counsel patients in that regard?
So it's interesting, kind of what Kathy was alluding to. It's discussion with radiation oncology. What does the patient want to do? Even in the Academy of Breastfeeding Medicine, one of our surgeons who is in the American Society of Breast Surgeons, she's very active because she too understands the importance of breastfeeding during this time. But in terms of potentially, whether it be for imaging or radiation, where patients can even pump or nurse right before it, if that potentially helps. So, actually, one of our colleagues who's still at Dana-Farber, at MD Anderson, Dr. Dominici, back in 2010, MD Anderson did a study looking at, well, what are the complications with surgery and pregnancy? And there was no big difference, but as far as me personally, it's really, again, a discussion with my colleagues, my radiation oncologists. At 2 weeks, I would be comfortable. It really kind of depends, and depending on the radiation oncologist you speak with, they all have a different opinion. Something though to consider that's, I think, very important is if a patient's undergoing breast conservation with lumpectomy, we often try, I think a lot of breast surgeons now often try to do these cosmetic incisions where we can hide the incisions, especially in the periareolar region. But in the lactating patient, you really have to consider and plan your incision accordingly, because if a patient is nursing and actively nursing and the tumor isn't right at the nipple and areolar complex, that might be a situation where you might want to consider planning your incision a little bit differently so as not to impede or affect nursing.
Got it.
There can be, it can be challenging intraoperatively. Someone, even if they stop breastfeeding a couple weeks before surgery, they're still going to be making milk. So, there's theoretical complications which may or may not happen. But basically, especially for patients who are doing breast conservation and you are kind of operating in a pool of milk, and milk has sugar in it. And so it kind of, creates the situation where someone might develop like a big seroma or like a galactocele, basically, that could be very uncomfortable. And also, in theory, could be a little bit more prone to infection. So I definitely think it's a conversation you have to have your patients. They're going to be asked to stop soon, if not for surgery. So if they're willing to kind of stop for surgery, I prefer that they do, but I don't think it's absolutely necessary.
What if they only breastfeed on the contralateral breast? Do you know?
That's fine. Yeah, I think it does. If they stop breastfeeding from the breast that you're operating on, they will decrease their milk supply there. So I think that's fair.
Yeah.
Agree.
Yeah, no, that's great. I think it's so nice to have all these different options so that patients, feel like they have ownership over that decision too, because there's so much that's being kind of taken away from them by this cancer at such a sensitive time in their lives. Good to know what the options are and that they have them in this case. So this is a patient where presumably we could do neoadjuvant chemotherapy, deliver, she could nurse for a period of time, and then have her surgery. And I think these are often patients too, whom I remember in this case, this was a 31-year-old who had not had children before this one. This was her first baby. And so she may be interested in future pregnancy as well. Obviously, because she was pregnant when she was diagnosed, we weren't able to consider things like, egg harvesting and fertility preservation in that vein. But she's young and potentially, could be fertile after this also. And so I think, from an endocrine therapy standpoint, we're going to be recommending at least 5 years of total endocrine therapy, if not a little bit more, because of her positive lymph nodes. But Erica, how do you counsel these patients about the possibility of pausing endocrine therapy to achieve a second pregnancy, and how do those conversations typically go for you?
Yeah, I mean, this is a very important part of what we discuss. And sometimes when patients are coming in with a breast cancer diagnosis, you know, you're sitting there as the medical oncologist really worried about their breast cancer, and they are much more worried about their fertility and their future ability to have children. So this is a really huge topic for patients, and something which has been the topic of a lot of research. Over the years, there have been many efforts to study the safety of getting pregnant after a breast cancer diagnosis. And some of the largest meta-analyses that have been done looking at thousands and thousands of patients very interestingly show that patients who choose to get pregnant after breast cancer seem to have improved outcomes compared to patients who choose not to get pregnant. This is particularly notable in patients who have hormone receptor negative breast cancer. They may have about a 40% difference in risk of breast cancer coming back. There's been so much thought about why we might see this. You know, perhaps there's something about the pregnant milieu that somehow treats breast cancer or prevents breast cancer recurrence. More likely, this reflects something called the healthy mother bias, where there's something about the patient, the provider, the decisions that are made that in some way indicate a less risky situation than patients who choose not to get pregnant. And even though all of these studies have used all sorts of multivariable analyses and matched on so many different clinical pathologic risk variables, there is just something unmeasurable that differentiates people who choose to get pregnant versus those who do not. If a patient has hormone receptor negative breast cancer and they're not taking adjuvant endocrine therapy, then this data is really very helpful and very useful to counsel our patients about getting pregnant after breast cancer. And many of us might suggest to a patient that they wait at least a couple of years after diagnosis and treatment before they try. It's also a very, I'd say, intensely personal decision, of course, but you want to, you know, talk about risk with that patient. And a patient who had a stage 1 breast cancer versus a patient with a stage 3 breast cancer, those are going to be different situations, and we might perceive our risk differently. The challenge, though, is with patients with hormone receptor positive breast cancer, because Jane, as you just said, a patient like this, multi-node positive, high-grade disease, she's going to be on adjuvant endocrine therapy for 7 to 10 years. She's going to be receiving ovarian suppression. This is not a program that is built to allow for windows to get pregnant. But of course, this is a really important question for patients. And so this was the basis of the positive trial, which is, in my opinion, one of the most important research studies we've had in breast cancer in the past 5 to 10 years. This was a global collaborative effort led by investigators in the US and throughout the world, honestly, that was asking the question, in patients with a history of hormone receptor positive breast cancer receiving adjuvant endocrine therapy who want to get pregnant, can we safely pause endocrine therapy, allow for conception, pregnancy, delivery, some period of time for breastfeeding, and then resume endocrine therapy? Is it feasible? Does it work? And how do these patients do? So this was a single arm study, that prospective study that enrolled patients globally over a period of many years. Results of the study were presented at San Antonio in the past year or two by Dr. Ann Partridge. And the results were very, very important. First of all, is this possible? Is it feasible? Yes. Patients were able to pause their endocrine therapy, typically beginning at least 18 months into treatment, wash out, and a significant number of patients were able to achieve pregnancy, either through natural techniques or through using assisted reproductive technologies such as IVF. Then the patients were followed long-term. And the authors of this study did a very important and interesting statistical analysis where they used a very similar cohort of patients from the soft text trials, which is young patients treated with advanced adjuvant endocrine therapy in contemporary times, and compared outcomes between those groups, and demonstrated there really was not a significant difference in how patients did, suggesting that the temporary interruption of adjuvant endocrine therapy for pregnancy did not lead to a decrement in outcomes for these patients. They did just as well as the historical control of patients who continued on endocrine therapy and ovarian suppression. And so this was really a broadly celebrated paper throughout the world. It's so practice changing, and it absolutely helps us in clinic when we're counseling patients. We can now offer this as an option for our hormone receptor positive patients taking adjuvant endocrine therapy.
Yeah, no, it's so well said and so beautifully explained. And I think it is lovely. I mean, coming from a time where we used to counsel patients that we think we can do this, but we're just not sure, to a time where we actually now have results from this study, it really is lovely to have that to back up this practice. One thing that I've been thinking about with some of my patients who've been down this road is that now we're also using a lot of adjuvant abemaciclib for these node positive, ER positive patients. And so patients based on the monarchy study are getting adjuvant abemaciclib along with their endocrine therapy for 2 years. So that seems like a nice place after that 2 years is over to pause the endocrine therapy and of course stop the abemaciclib and then potentially allow for pregnancy. But that, as standards keep changing, it adds more into the mix.
Right.
But I think the message of a positive trial does not change at all in terms of it being absolutely safe to interrupt endocrine therapy and achieve a second pregnancy for patients like this.
And I would just add that sometimes in these patients, we might offer adjuvant zoledronic acid as some of the Lancet meta-analyses. That's a strategy that I personally do not tend to offer patients who are considering a future pregnancy. I think we don't have great confirmation about the safety of something like a bisphosphonate that goes to your bones and stays there forever, whether that's safe to give in someone who might in the future become pregnant. So that is one aspect of treatment that I tend to leave out in these situations.
Yeah, thank you. I think that's a really important nuance to take into consideration too. Excellent.
Jane, if I can add too, I think something that's really important when we're treating these patients that Kathy's highlighted regarding breastfeeding, Erica regarding, the potential future for additional children, and something we didn't get to speak about, but in surgery, an area is talking about actually reconstruction as well. So we really want to think about, again, taking care of both patients, as Erica said, but leaving options open. And so at Dana-Farber, a little over 10 years ago, I know we did, for example, a study looking at the safety of immediate reconstruction in these patients. And what that study found was that, even though it added roughly about 45 minutes of time to the procedure, and it was basically the placement of tissue expanders, it left options open for patients afterwards as well. So again, considering the safety, obstetrical data, it was all, safety was there, but keeping that option open for patients is really, important. So I just wanted to throw that in there.
No, I think that's perfect. It is so important to consider for these, especially for these young patients for whom, again, like so many decisions are being taken away, and to be able to make those choices for themselves is so useful. In the interest of time, we'll go on to our third case. And again, definitely happy to take questions at the end. So this is a 35-year-old G2P2 this time, presents with a palpable mass in her left breast. She has a mammogram and an ultrasound that reveals a 4.2 centimeter mass and at least 2 abnormal appearing nodes measuring 1.8 and 1.2 centimeters respectively. She has a biopsy of the mass and of 1 axillary node, and this reveals grade 3 invasive ductal carcinoma. It's triple negative, as you see, with a high Ki67. She undergoes genetic testing and is found to carry a BRCA1 mutation. She and her husband have 2 children, and they've been trying to conceive their 3rd child. She's missed a period, and a pregnancy test done at the time of breast cancer diagnosis is positive, and ultrasound reveals an 8-week intrauterine gestation. It's a little bit of a different case. This is a patient who didn't know she was pregnant, was diagnosed with TNBC, is found to be a mutation carrier, and then at the time of breast cancer diagnosis is found to be pregnant with a wanted child. So moving on to some of those questions. So first, I think thinking about this patient and her breast cancer, it's node positive, it's triple negative, she's young, but she's also pregnant. And so, I think one of the first conversations we're probably going to have with her is about that pregnancy and what to do there, but also what about staging of her breast cancer? Erica, can you speak a little bit about the staging workup in pregnancy? I know we've spoken about mammogram and breast imaging, but what kind of staging workup can you do during pregnancy, and how would you approach this if the patient wanted to do this at this time?
Yeah, and the majority of breast cancer patients do not require systemic staging, and we typically would only pursue that for stage 2B or stage 3 breast cancer diagnoses, or if there's a really kind of worrisome symptom. So we actually are not staging many of our patients, and we don't have to. In this situation, though, she has a larger cancer and has multi-node positive, so this is a situation where staging is reasonable. For the majority of my pregnant patients, I tend to do a limited staging with a chest x-ray and an abdominal ultrasound. Technically, doing something like a CT scan, a chest CT, is possible in pregnancy, although again, anecdotally, I'll say my radiology colleagues don't really like doing that, and I get a lot of phone calls when I try to order that. But an alternative, if you're really worried and you need to do a more intensive staging evaluation, is to do a whole body MRI. And that's a complex test, but in a situation where you really have a lot of concerns and where the diagnosis of metastatic breast cancer is really crucial to make, then that would be an alternative to consider.
Yeah, perfect. I think that's very helpful. And I think in this patient, assuming that you do a limited staging workup and that staging workup is negative, I think some of the advances that have been made in triple negative breast cancer make this in some ways a little bit more complicated. It used to be that the standard of care from a chemotherapy standpoint would be to give ACT, all 3 drugs of which we've discussed are safe to give during pregnancy. But now it's, as you stated in the very beginning, we have to consider what will we do for this patient if she weren't pregnant, what can we do for this patient now that she is, and how do those things differ, and what compromises might we have to make. I think one of the challenges now with like locally advanced triple negative breast cancer is that the standard of care for this patient now after the KEYNOTE trial would be to give chemotherapy plus immunotherapy, and we really can't safely give pembrolizumab during pregnancy. So this would be a challenging situation. How would you approach this as in your conversation with her?
Yeah, it used to be much more straightforward to treat triple negative breast cancer in pregnancy, but I mean, our field in general is so lucky that we can now use pembrolizumab in the preoperative setting, and we know from KEYNOTE 522 that giving pembro not only improves the rate of pathologic complete response, but also substantially improves the event-free survival, whether or not a patient has a PCR or a non-PCR. We also know that giving immuno-oncology medications really needs to happen while the tumor is in place. We really don't have any data that it works adjuvant after surgery, so we have to be giving it in the preoperative setting. And so here's where, like similar to HER2, we have to begin to try to adjust and make compromises. In contrast to HER2 positive breast cancer, however, where we do have the data that you can delay administration of the HER2 directed therapy and give the rest of the chemotherapy beforehand, we really don't have that data. That's not how KEYNOTE 522 was designed. And I think we all begin to feel quite uncomfortable if we begin to deviate too far from what is now the standard of care and much better than the previous standard of care. So here's where we begin to, have the situation of a compromise that we will feel that is going to lead to a decrement in efficacy of our treatment, and that could put the person, the mother, at more risk than she would be otherwise. If someone's later on in the pregnancy, then they can get, let's say, AC times 4, deliver baby, then get carbotax pembro afterwards, and that, that's a way to address it. But the challenge is really these people diagnosed, early in the first trimester, where you have 6 months ahead of you, and you're going to be delaying that time to IO treatment. If somebody strongly wants to keep their pregnancy, and that is their plan, then you can give them dose-dense ACT, and then you deliver, and then you can change the T into carbotax pembro, and you give them more treatment than they would have otherwise had, but at least you can be treating them. But a situation like this is the thankfully rare time when I begin to talk about with a patient, is this really a pregnancy you want to keep, and is this worth it for you? Because if you keep it, you are going to encounter a loss of efficacy of your drug. You're not going to get the best drug I have for you. And here's where we really need to work closely with our OBGYN colleagues to have those conversations. I'll say, in my oncology fellowship, talking about termination of pregnancy was not something we were trained in, but but I am grateful to have colleagues who are expert at having these conversations and in providing service if necessary.
Yeah, and I think that's all so well said, and it is so hard when these situations come up, because we, one of the best things about having all this information that we have about safety of chemotherapy during pregnancy and being able to do surgery and even sentinel node biopsy and all these things is that there are a lot of patients who can safely continue their pregnancies. But I do think it's also important to talk about those situations where that might not, where you may have to make too many compromises in the care of the mother to make it feel like a safe proposition, particularly for those patients who come in who already have, several children and who need to be around to raise those children. I think these questions do come up and are really, really hard. Kathy, Economy, how do you discuss this? How do you discuss termination with these patients, and how might we learn from some of your experiences in addressing this concept sensitively?
Sure, it can be a very challenging and nuanced conversation. So first of all, you can never really start with the assumption that you know that the patient's going to agree with your perspective, right? Your bias, which is we are here to protect maternal health. We are here to make your cancer go away and to sort of like, increase your longevity. And that's the bias and the assumption that we bring to the table. So it's really important that when you sit down and counsel patients, you sort of remove that from the picture and you say, here's what we know about the cancer that you have. Here's what we know about the best treatment. Here's what we know happens if you don't get the best treatment. Having a termination of pregnancy, abortion is healthcare. Abortion is a medical procedure that can be used to save people's lives, and we present that to them in that way. You will get a wide range, I've learned over the years, of patients with different perspectives, different values, and as long as they understand this complex counseling, and many times you do it again and again, and they need and want to hear it again. The first time they might not take it all in, and so we'll say, let's meet again in a week, let's talk again. We are, of course, often with abortion running up against gestational age limits. Sometimes you're running up against legal limits. And I think it's really important to know where you are and where you're practicing. But the goal is to allow the patient to make a sort of patient-centered decision and to help them make the decision that feels best to them once you've given them the information. And I will say, it's very clear to me that we would know what to do with you if you weren't pregnant. And this would be an obvious medical choice as the best way to receive care. And then I'll say, what does this feel like to you? Tell me how you see the data that we've presented here. And I have learned over the years to never guess in my mind what they're about to say. And they're going to make the choice ultimately that's best for them and best for their family. And then our job is to sort of guide the rest of the steps.
Yeah, no, that's all so well put. Thank you for that. Anything else that you all have to add on this case in terms of how you would pursue it? I think if this were a patient who decided that they wanted to continue the pregnancy against all potential counseling, maybe not to, then you would have to think about those other things in terms of, do you do ACT once the patient reaches their third or their second trimester? And as we've talked about, after 12 weeks, this patient could start chemo, and then think about surgery later in the pregnancy, and that would probably need to be the contingency plan, or as you said, potentially doing carbotaxol, pembro afterwards if you can, to potentially give them more benefit. But it's interesting with some of these later developments, we are running into bigger challenges just because of the safety of some of these newer agents during pregnancy. It's just something that's an unknown. So I think that's great. I think we've got 7 minutes left. I don't know if we have any questions from the audience. Asa, do you have any questions to present to us?
Yes, Dr. Mizell, I can see one question. Perhaps it might be better if I just gave you the question. Would that be okay? Oh, I'm seeing a couple of questions. Okay, hold on here. Let's see. Related to the topic of breastfeeding, do you have any data to recommend amount of time between cessation of breastfeeding and prophylactic surgery, since timing of surgery is much more feasible than in our cancer patients?
I see this, yeah. I'm guessing that this question is related to patients who may have a mutation or something like that and require prophylactic mastectomies, as opposed to patients who are receiving mastectomies for cancer. I guess
So I think
kind of the surgeons for this question.
I think in this particular instance, because it's for prophylaxis, again, it's a conversation with the patient. What is their desire? How long do they plan to nurse? And again, how are we screening them? As Dr. Economy pointed out earlier, in patients that are at higher risk, there are ways that we can screen. So I think the critical point here is just to find out from the patient, how long does she plan on nursing for, and just reminding them this is for prophylaxis, so it's not for the treatment of an active breast cancer.
Yeah, and so we have lots of options and the luxury of time in this setting. So I would say especially in someone that we're planning reconstruction for. We really don't want to compromise a prophylactic reconstruction by being too close to breastfeeding. So I typically say like at least 6 weeks, but probably at least 2 months. And I think that's what my plastic surgery colleagues would probably feel the most comfortable with in terms of placing an implant. Obviously, in the setting of cancer, we can shorten that timeline, but for prophylaxis, there's no urgency to get to surgery kind of in a specific time.
That's perfect. And then another question, this is probably, Dr. Economy, is more directed towards you. The question is, acknowledging the major restrictions on reproductive rights and abortion access across the country, if we have colleagues practicing in states with restricted abortion access, is there a resource to get patients safe abortion care in other locations? As someone practicing in the South, I am also very interested in this answer.
Yeah, there are, and certainly maybe I should collate them and we can share them to the people who are on the webinar. I think that for sure Planned Parenthood that exists in every state is responding to these questions, and in whatever way that they legally can allow, they are sharing resources locally. Many local providers are terrified in states where they don't have access to even share resources. I think that any of the programs with family planning programs, you can call them directly. Any major hospitals that have sort of like the Brigham Women's Hospital, you can call our family planning program directly. You can email any of the heads of family planning, and they will certainly share the resources with you directly. And I'd be happy to compile a list for people on the call.
It's fantastic. Yeah, such challenging days we are living in. That is for sure.
Go to the polls and vote.
Yes, yes.
Always vote.
Also an excellent point. I think those are the only questions that popped up here in the chat. If there are others, I know we would all be happy to take questions after the fact. And then just want to thank this wonderful team and ask of those of you on the panel with me tonight, any other thoughts that you have to share or things that you felt in the cases didn't come up that you wanted to explicitly make sure our audience is aware of.
I would just add that each case of breast cancer and pregnancy is unique. Each situation is entirely different than the next. And, that we don't come up with these treatment plans out of a vacuum. This really takes a village, and it's not just the multidisciplinary village, but, we send emails out to colleagues around the country. What would you do? What do you think? So, if you are dealing with a challenging case, like, reach out for help. Like, we're all here to help each other, and we all want the best for patients. And, if there's something that you don't know how to do or you have questions, please call one of us.
Yeah, no, I think that's absolutely right. And I definitely take advantage of that all the time. And I'm always grateful when people take advantage of that and reach out to me. I think it does, it helps to have a village. And in these challenging cases, I think helps patients also feel comfortable that you've reached out to others to back up your plan.
Yes, please share my email. I'm always happy to hear from people, especially if you don't know any maternal fetal medicine specialists to talk to, and happy to answer any questions.
That's so great. Thank you. Thank you all. This has been such a wonderful discussion, and really appreciate all four of you being on this call with me tonight. I know we've all learned a lot and thought about a lot, and I think these cases will hopefully help us all in our practices as we think through how to handle these cases in the future. So thanks everyone, and I hope everyone has a great night.
Thank you for having us.
Thank you.